Good afternoon and welcome back to this teleconferencing of PGDHHM program. Before we went for break, we have discussed about the remaining areas of the course 4, and Colonel Rao has very well explained about the laboratory services and the radiological services. And now after finishing the course 4, now we'll move on to course 5. And if you see the title of the course 5, that is Sport and Utility Services and Risk Management. So there are certain areas that you will agree that the hospital is a multidisciplinary organization. And it has got certain areas which we have already covered. But there are certain sports services which may have not directly effect on the medical care, but they are definitely there to improve the quality of the medical care. And therefore we call them sport and utility services. And in this we have got CSST department, medical record department, linen and laundry services, dietary services, housekeeping services. And if you see all these things, which 4 or 5 names which I have just told about, they are somehow or other are affecting the patient care. So it's very important to know about how these departments, various departments, ancillary departments, sports department, utility services, how they supplement and complement the hospital services. So discuss about these two, these utility services. We have with us Dr. Bidhan Das, and he will be just talking to you in next 45 minutes about medical record department and the linen and laundry services.
Mortuary. Mortuary services.
Mortuary services. Okay. So without wasting any time, we will go on to the medical record department. And I think you will all agree with me that medical record department is a very crucial area in the hospital, and it is the most neglected one also. There hardly any emphasis is given upon that. Whether we are as our medical during the medical students days, during our internships, housemanship, and even when we are working, we give very least importance and we leave it to our clerical people, and we are not bothered about that how they are managing. And but there are very useful inputs this medical record department gives to improve the quality of it. Like if you have been told about what is medical audit. Because medical audit we can't do unless until the medical records are complete. So it becomes very important to know about that how this planning and organization of medical record department is done, what are the various records which has to be maintained, what are the various data which can be generated out of this medical record department, and how that data can be utilized to improve the medical care services. So I will request Dr. Bidhan Das to tell our learners about some of these aspects of the medical record.
Thank you, Professor. So I'll just quickly take you through medical records and then possibly some time on mortuary and of course linen and laundry. So let us see now in the next 45 minutes we need to cover up these 3 chapters. So first starting with medical records. So you can have a look at the presentation also, and I'll define medical record department as what are medical records. So it's a repository of all information pertaining to patient's health history, and thus it contains information to diseases for diagnosis, tests and examination, therapies, follow-up, prognosis and discharge status. So this is the complete definition of a medical record. And in simple terms, it talks of what, whom, what, why, where, when of patient care. So these are the reasons why, and many a times we have a disparity on keeping either OPD records or IPD records. So hospitals all over the country, they have a problem on keeping or storing either of them. So both OPD records and IP records are important. So what are the contents of medical records? So contents, as you all know, are predefined. The contents of a medical record are usually predefined. So they have a phase sheet, they have a history sheet, they have a continuation sheet, intake output chart and so on and so forth. But By and large, you have these following details: personal and demographic profile, clinical notes, that is the continuation sheets, case history, diagnosis, treatment, investigations undertaken, and discharge status. So these are the contents that should be clearly stated in the medical records. Well, there are different types of medical records. So the colloquial terminology that we use is a manual method of record keeping, in which we have a paper. But some hospitals do have some paperless techniques, and these are quite age-old techniques, which are microfilming, optical disc, tape, and computer drives. So nowadays we have a EMR, electronic medical record, which could be generated if you have a well-defined HIS, which can take all the reporting from the notes if it is entered properly. Well, I'll not go into all that. What are the elements of medical records? So there is something which is input. You have to write into the medical record. So that is called input. And as in quality, there is always input, process, and output. So therefore, wherever there is input, we need to analyze. So there is something which is analyzed, and then they are processed, and of course then comes what is output. Then we need to store the medical record. There are very many modes of storing a medical record: retrieval and of course the flow. Now we have quickly defined about what are the types of medical records, and therefore we have admission forms, which I have listed in the beginning. One is the admission form, the nurse's bedside records, the operating notes, the discharge summaries, and so on. Discharge summary should be an important component, and when the medical records are closed and they are kept in the medical record department, the discharge summary should be the first sheet of the closed file. And of course the ICD coding and so on and so forth. We'll talk about ICD coding quickly. Now, what are the characteristics of medical records? They should be complete, should have sufficient data to identify patients, justify the treatment, investigations, etc. They should be adequate. All necessary forms and all relevant clinical information should be there. Now, the issue is most of the time, if you see, they are not adequate, and mostly I won't define or differentiate between public or private hospitals, but either of them, they are probably inadequate, and all the forms necessary are not probably tagged into the case sheet. Accurate and capable should be capable of quantitative analysis. What Professor Arra was saying in the morning, in the beginning of the lecture, that is medical audit, that is quantitative analysis, and of course that will give some element of qualitative analysis subsequently, because medical records are of two types: medical audits. One is a medical audit, and of course one is a clinical audit. Clinical audit has a different connotation, where you analyze clinical competencies or the treatment given to the patient. That is clinical audit. And medical audit is a retrospective analysis of the case sheets and confirming whether the case sheets are complete in all forms or not. What are the scope of importance for patients? They assist in continuity of care, avoid omission, repetition, duplication of investigations. Many a times this is a common query, and mostly in the consumer protection forum, you'll have these kind of cases coming up when the doctors or the hospital is accused of repetition of investigations without understanding. Probably there's a different perception, which I will not go right now. Evidence to support or refute medical legal questions. So if you have a records complete, that is the only instrument or tool which is going to save you in some form or other in a case of a dispute, or in a case of the consumer's dispute. Documents of story of the patient. It has to be chronologically listed as to the total events which the patient undertook during his journey in the hospital. Ready information for life and health insurance. Well, this is an important component both for life insurance as well as health insurance. There is a patient who is probably no more, and the children have a dispute over the property, and therefore the LIC or the life insurance authority would have a look at the medical records and decide and probably give the judgment as to who would be the beneficiary of that kind of will. Disability entitlement. Supposing the patient is claiming an entitlement for disablement. So, well, he does have a disability certificate given by the competent authority, but then a medical record is also an important tool for that. Assurance of adequacy, quality, and continuity of care. Well, this fits into the total definition of medical audit. Helps in evaluation of medical care. This is, well, clinical audit, which I had told you that medical audit and clinical audit are two different things. And here the second point helps in evaluation of medical care, that encompasses the clinical audit. and of course protects you from legal suits. Documentation as evidence for evaluation of medical and nursing care, helps in the management of planning and allocation of resources, protects in cases of legal. These are all important issues that we need to be concerned about. Well, I'll not go into. I'll quickly. What are the importance for public health authorities? Public health authorities, I think all of you understand there are some statutory reports that have to be given to the state, because health is a state subject, and all the common things that you would know is probably the births and the deaths. Notifiable disease is one, and of course one important thing is the disease profile. The disease profile internationally, we know there are 5 disease profiles internationally. One is cardiology, second is oncology, third is trauma, fourth is infectious diseases, fifth is maternity and childhood disease. And these are the international disease profile. Whether we are fitting into that kind of internal disease profile or not will not be assessed unless we provide the data to the competent authorities. Competent authorities of course the Director General of the Health Services of that particular state. Well, from there it goes to the Central Institute of Health Vigilance, and from there it goes to the CRO office. From CRO office it goes to the Geneva office, and then the data is published in the World Health Report, which is readily available by the month of August every year. Well, therefore, it has to be a reliable information regarding mortality and morbidity profile of the population, assist in planning and preventive social measures, provide early warning of incidence of communicable diseases. Well, this is a typical organization of MRD which any hospital could have. Here, typically we are looking at the Department of Medical Records in All Institute of Medical Sciences. Well, we have an admission office, there is a ward or nursing unit, there is a central record office, because they all are under the control of the medical record officer. Now, this is the space requirements. I do not know whether you would require to design a medical record department at any particular time of your career, but then if you need to design, these are the requirements. And this is the staffing requirements for any medical. The staffing is the issue because not many trained medical record technicians are available, and normally hospitals would appoint a ward boy or a nursing orderly or a clerk to handle this department. Unfortunately, he is not competent enough to do it, because he does not know what is ICD coding, and it is very difficult. Well, ICD coding is very simple, because unless it's available in a soft copy from the WHO office in Delhi. Well, it is available other WHO offices as well. EpiInfo does have an element of ICD-10. Some hospital information systems which are recently done up, and they would have a component of ICD-10. So if you have the diagnosis written there, it will automatically pick up the ICD coding therefore. So, and ICD coding, I hope you won't know, there are 21 codes for different diseases, and A, B, therefore alphanumerical coding is there. Well, this slide is most important probably if you understand how it happens. So, functional organization of a medical record department, and these are the various functions that are allocated in the department. If you see, the chief of the MRD controls all the functions. So therefore, there is an assistant chief for personnel training and medical correspondence, assistant chief for central transcription. Transcriptions are not usually done, but sometimes they are required, because if it is not too clear, the letters are not legible, then you need to transcribe the whole document again and type it into the HIS if need be. Well, there is an admission office, there is a medical correction and abstraction office, relief correction, appointment and admission. Well, these are the furniture fixtures required. Responsibilities of medical record department. Well, designing of hospital forms. This is very important, and probably very seldom this takes place. And nowadays, since the onset of this concept of quality and the NABH accreditation, so hospitals are in a state of readiness to prepare and design forms that are required. So designing of an admission form, designing of a discharge form, designing of a data collection tool, designing of an intake output chart, designing of a diabetic chart, designing of a, so on and so forth. All these charts are very important. Some medical records are mundane, so therefore you need to innovate, keeping in mind your own hospital. It could be in the form of a booklet, it could be in the form of a couple of sheets, It could be electronically formatted. It could be, if your hospital is paperless, then it could be on the HIS in electronic format. And therefore, if the EMR is built into the HIS, it will automatically generate a discharge summary. It will automatically codify, and therefore all these intricacies are resolved if the HIS is well designed. Well, census is an important component. Census is usually on a midnight census at 11:59 p.m. It should be available and generated by the nursing staff and submitted there to the medical superintendent, goes back to the medical record department. Census gives a day-wise calculation. If you have a census proper, then you can calculate utilization rates, ICU utilization rates, OT utilization rates, ward utilization rates, and so on and so forth. It gives you and gives the casualty medical officer an indication as how many beds are vacant in each and every ward or a facility, so as to encompass or enable him to admit the patients during that part of the night. Well, checking verification correctness of every record for inaccuracies, incompleteness, coding, and indexing. So indexing is a method by which you have to keep it on a rack, and then which will enable you to retrieve when you require. Codification is, of course, ICD-10, and probably next 1-2 years we'll have ICD-11. Now it is ICD-10. And filing according to predetermined system. Well, predetermined system, if you have racks, you need to have medical records in your possession for the last 10 years. So if you need to have space. You can have color-coded files. The first file could be the current year on the topmost rack. The second row could be the last year, and the third row could be the year before the last. The first row could be orange. The second row could be green. The third row could be yellow, the fourth row could be red, color coded. It gives you a nice look and feel. Compiling hospital and diagnostic statistics. Well, this every hospital manager would do it, because that is what is paid for. He must compile the hospital statistics, because, and of course, not only diagnostic, the procedures, the revenue, because if you have an HIS, then the HIS is built in, so it will give you some reports, but on a day-to-day basis, on a manual method also, you can collect the data and analyze and submit it to your authorities to justify that your hospital is performing well, doing well, both in business and, of course, utilization. Generating reports for administrative, well, this is what we discussed. Yeah, how is a medical record processed? Well, it is initiated from the admission office. Well, admission office, there is someone who advises admission, and the patient is admitted through a competent person who is the admitting authority. It might not necessarily be the professor of that department. It could be anyone as defined in the hospital policy. Well, it is initiated there, and then there is an assembly. When there is a census, then the assembly and deficiency check desk, incomplete records control desk, admission and discharge analysis, coding and indexing desk, and filing. These are the steps in the medical record department. Now, well, the case sheets, after they're closed. Closed and open, the two terms that we use. Open means the current files. Closed means after the discharge, they're called closed. Now, closed can both be done in a manual method as well as in an electronic format. Well, manually they are sent back to the medical record department. When thereafter you should not be adding or deleting any entries in what you have already done. But electronically it is pretty much comfortable, and it is pretty much secure. Well, these are the responsibilities of the admission office, and well, they are not standardized. There could be different protocols followed in different hospitals. So not necessarily they are the correct thing. This is what is followed in one hospital, which could be different from other hospital. OPD registration. What happens many times in the OPD registration, where the case sheet or the OPD card is initiated, what happens, the patient comes to, and there is a process called registration process. Registration process, the patient is supposed to give the demographic details, age, name, sex, and address, and of course pay up some fees if need be, 5 rupees, 10 rupees, 50 rupees, as and when desirable by the hospital. That is called the registration. And thereafter, this is either fed onto a computer or entered into a register. Either, if it is a manual method, it is entered into a register. If it is an electronic format, it is fed into the computer, and that data is kept. So that is called the registration process, and after the registration, the patient is sent to the OPD for a consult with the doctor. Well, in the wards, the nurses and the doctors, the residents and the the consultant in charge have to write all that. Well, history, examination findings, diagnosis, investigation and consults, treatment and progress notes, education, evaluation, and lastly is the discharge. Well, I'll just quickly tell you about what is the storage time. I mean, these are pretty much standardized, and there have been a lot of judgments passed, and therefore you must keep all these records. OPD records should be kept for 5 years, indoor records for 10 years, medical legal for 10 years, or till the cases are on, and some on cases for 25 years at least, or till required. Functional activities in the medical record department. Well, there is something called a numbering. It could be serial numbering, it could be unit numbering, or serial unit numbering. It could be mixed method. You can start from if your calendar year is January or your calendar year is April, you can start from that year to this is 1, 2, 3, 4, 5. You can have an alphanumeric system. You can unit system. The different units, they have a different codification. So either way, you can start that. Well, filing. Filing is something which we can have decentralized and centralized. In decentralized format, OPD and inpatient have separate records, and well, you can have a separate storage for OPD record. You can have a separate storage for IP record. It's not necessarily a good habit or a good practice. You can have all the records centrally. It is a good habit to have a central system, wherein supposing you have an appointment system in the OPD, and you know that probably tomorrow is Monday, and these patients are given an appointment, so all the records are retrieved at 7:30 in the morning and kept in the OPD for the doctors to see the patients. Well, if the patient is a walk-in, you can have a new registration and have a new card, but all the follow-up cases are given beforehand to the OPD. Well, that is the advantage of a centralized method. So decentralized method is we keep the OPD records in the OPD, or there is a storage behind the OPD reception, and the person keeps it. Well, some hospitals do not keep all, because they only have to keep super specialty files like cancer, neurology, cardiology, cardiac surgery, and so on and so forth. It's a good habit or a good practice to keep all the records, because not necessarily general specialty patients are not coming for follow-up. They do come for follow-up, and it's a good practice to keep all the records. Hospitals, for the lack of space and other issues, they probably don't keep all these records.
So normally what has been seen that the inpatient records are being maintained properly. But there is a hard, if you see across the hospitals that the keeping of the outpatient department records is somewhat lacking in.
That was what I was coming to, and well, it is in our experience, and of course Colonel Rao will also agree, it is the situation everywhere, and there are issues, sir. I mean, it's not necessarily by choice, because hospitals, even if they want to, they probably do not keep up because of resources or space. Resources also include space. Resources also includes manpower. One, they are hesitant to keep additional manpower. Two, they probably have a resource on account of space constraint. But they do appreciate that it is an important issue.
It is important because they go in a long way in improving the.
Yeah, but therefore sometimes some hospitals do have a dual method. So general specialties, they don't keep a OPD file, but super specialties like cardiology, oncology. I think Dr. Colonel Rao, will you agree with that? Will you comments?
Definitely, especially when you have super specialities, there is a requirement of keeping outpatient records. Also, in the outpatient records, it is very easy if it is a captive clientele. Like we in the armed forces, we have a captive clientele. There we need to perforce maintain all OPD records, because the patients are going to come back again and again to the same doctors and same hospitals. But otherwise, in other government hospitals also, as Dr. Das pointed out, OPD records have to be kept for super specialities and such specialities like eye and dental, where everything is dependent on OPD itself, OPD record itself. So there, this requirement is a must.
Well, I guess
But these are required.
they are required, and I think you would agree with me that if you go across the country, public hospitals as well as private hospitals, they do have some element of record keeping. If it is a manual method, let's talk of for example, All India Institute or LNJP hospital or other public hospital. They have a register in which the patient's demographic details are maintained. And that register probably goes, and at the end of the OPD, there is some provisional diagnosis also mentioned. They have a column. So in some rudimentary form,
They are there.
it is there.
Even,
But
even in Delhi administration now, I've seen that they have also computerized their records.
yes,
At
if it
least
is electronic, probably it makes a comfort.
they may not be having the diagnosis part, but the other things, the profile
Yeah,
of the
yeah.
patient and that all those they have.
Yeah. Since many hospitals, you are right, sir. Many hospitals do not have a complete HI, so they have computerized the OPD. So in that, computerized the lab. So in those situations, also they probably have some record keeping. But otherwise, if you see, go back to your own facilities and see a public hospital, I think that register is also there, because at the end of the day, the CMO or the head of the hospital has to understand as to how many patients did come. They have a mixed peculiar method: old patients, new patients, and male and female. Typically in a public hospital and district headquarter hospital, they have this distinction also. Well, I don't think there is any difference in maintaining so many records. There should be no one record, how many patients, because the doctor sees patient and utilizes the time. So it doesn't necessarily mean that you need to keep a male register, a female register, a old file and a new file. It makes a very cumbersome. What do you have to say, Kunal?
Yeah.
I think you have experienced the same thing?
Yes. it should be.
Age-old practices which take time to go off. They are in the beginning phase, like in CGHS in Delhi.
That's right. Yeah.
They're all computerized now, so all OPD records are in computer for every patient, as and when the patient comes for the revisit.
That's right. Yeah.
And there are certain diseases, not like ICD coding, but they've got developed individual codes for all the certain diseases, and the statistics are maintained in that manner.
Yeah.
So OPD sometimes recording can be also maintained
Yeah.
if the things are computerized, and I think lot many places are now being computerized.
Yeah.
Basically, that will also give us reflection that what kind of drugs we have to keep in our pharmacy and all those things, and how many doctors doctors we have to keep,
Yeah.
what type of
Yeah,
specialties
depending
we
on the
need to do
demographic
that.
data, individual areas, like if suppose there are certain area which are all senior citizens,
Yeah.
the disease profiles are different.
Yeah.
Where it's a mixed population, disease profiles are different. So as Dr. Arora said, that we do have that data for helping us to know what
Yeah.
medicines also to be kept in that particular unit.
Yeah, I
So
guess
OPD does help.
Yeah, I guess these systems are pretty much now enforced by the Director of Health Services in particular states. Delhi for sure, yes, they have given a CD to all the hospitals where the disease profile of that particular month has to be sent, and you can submit it online.
Yes.
So as to make the directorate very competent to analyze the disease profile or the patients, where are they coming from. Not necessarily your hospital is located in Kidwai Nagar. You don't get patients from Kidwai Nagar alone. You get patients from everywhere. So that is how it is.
And I
So
think that, as you were saying that earlier it was not possible. Now with the availability of computers and the
Now things have
availability of the software,
Yeah.
I think it become easier.
Yeah.
Only thing is that, as he's saying, there has to be will there.
Sure, sure. Yeah.
Once the will is there,
Yeah.
I think this can be done easily.
That's right, yeah. So there are tools now. If you have captured the data and you just put it on EpiInfo, it will give you a graphical map from where the patient base is coming from. They're good tools, and if you apply them, it will be very interesting. All right. So next is a deficiency check. Deficiency check is a department in the MRD wherein the technician, the medical record technician, has to identify what are the deficiencies. Deficiencies are incompleteness or illegibility. Two things more, and if at all they are illegible or deficient, then the medical record technician has to call that particular doctor. So therefore, it is now mandatory for all the doctors to sign name, date and time. So this is how it is rhymed. And please propagate this idea that they must not only sign, it must be named, dated and also timed. Because how will the medical record technician know who is this person who is given an initial? It is very difficult for him. So you must name that. So these are this is called a deficiency check. Second is of course indexing. Indexing, you can have these types of indexing. Well, patient alphabetically indexing, which is not probably all that good. Some hospitals do have an indexing in terms of registration number or they have got something called UHID, Unique Hospital Identification Number. UHID is the term which started after the onset and practice of this HIS, Hospital Information System, but otherwise they had other kind of indexing codes, disease index and of course unit index and operation index. Well, filing is horizontal, vertical. Well, either way you can do it. Vertical is always better. I mean, it looks nice. It is on a rack. It looks beautiful. Horizontal, you tend to accumulate all those files and then tie up with a cloth, and that is a bad practice, and it is very difficult to retrieve. So horizontal practice is a better practice. Please try to practice that and advise your people in respective hospitals. Well, will you have compactors also? So compactors are nice if you have a vertical planning. So you, supposing you are working in a huge hospital, well, and to keep a record of 10 years is a humongous task. Sometimes you need to have compactors. So in a compactor, you can't possibly do a horizontal filing. Horizontal is not probably right. It has to be vertical. So it's very easy. By the side of the file, you can see the code and just pull it up and put it back. So in the filing index, there is a master list where you have that either on the computer or on the side of the rack.
They have roller skates racks where the files are put in the particular folders that they are rolling around, so you can easily retrieve whenever you require.
That's right. Yeah. Well, the forms, I think forms should be uniform in size. Standard practice is to have A4 size forms. Even if the half the form is used, it is better to have a A4 size. Because it not only encompasses doctor's notes, it also has nursing notes and physiotherapy notes and dietitian notes and so on and so forth. Well, I don't want to, we'll just quickly take, well, this is the slide that you must understand and have a look at this. There is an entrance zone, there is a reception and registration, and of course there is a central admission office, and then assembling, incomplete record control desk, complete record control desk, coding and indexing, filing, storage, retention, and then of course the reporting and analysis. Reporting, we have told you what are the things, the reports that you need to make. Some hospitals do have a decentralized file of type of reporting. It's very commonly they do births and deaths, which is in the municipality in the state of Delhi. Well, there are different states and we have different set of birth and death analysis. It's not necessarily births and deaths, it's a disease profile, and sometimes if you PNDT, I don't know, because PNDT sometimes it is, the reporting is done directly from the ultrasonologist to the competent authority. It should be centralized so that we know what are the reports, and notifiable diseases are also another important tool. There is a lot of disparity because many hospitals and many doctors who probably do not know what are the notifiable diseases and when is that they should be reporting and who to report. Well, they treat them, and you know they have a case of cholera, they probably don't admit it and send it to the infectious disease hospital and so on and so forth. But these are lack of, I would probably attribute to lack of knowledge, and so there's nothing, we must report to the competent authorities. Well, nowadays there has been a lot of discussion and talk about electronic medical record, or they call it as PMR. The age-old practice was a manual method of record keeping. Well, there are advantages, there are disadvantages, but I guess with the advantage of technology that we have, we can adopt any kind of techniques for ourselves. We can have a scanning technique, we can have a compression, we can scan the whole documents including the X-rays and the CT scans and the MRIs, and then probably compress it and keep it in a CD or on your website, and we can have an EMR directly from the hospital information system. Well, there are other tools which is called microfilming. Microfilming is also a very old technique, but it is not probably used very often here in our country. EMR is being not discussed about, and probably now people who are on HIS, they will use EMR more often than the older method. But I guess some hospitals at the current period of time are using both the methods, manual method and electronic method, because the doctors still probably have not been adapted to enter onto the SSC. And number two is probably the hospital finds it very difficult to give one unit to each and every doctor in the OPD. So there are issues involved there also. We can't blame it only to the doctors who are not entering their findings onto the computer. The hospital might not have given enough computers, so there are problems on that part also. Even if the nurses, I guess, they have now well trained, and the HIS provider makes it a habit, and in its terms of reference, it is very clear that they must conduct training programs. But they do train nurses as well as doctors. There are issues. As of now, I don't think. Kalra, would you like to comment? How many hospitals would you think that completely done away with manual method of prescribing? It's very,
No, very,
very less, and not necessary. You might, you know. Well, some legal aspects are there. So there is something called confidentiality. We must maintain the confidentiality and secrecy of information on account of the patient, and should not be issued to anyone without the consent of the patient, and therefore any retrieval of the medical record from the medical record department has to be after proper authorization either from the medical superintendent or the chief of the hospital. I will not go into the legalities where all can the medical record be sent, but yes, it is a document which can be solicited by the court of law and of course the insurance authorities. It is there is a conflict as to whose document is it. It is the patient or the hospital. We know very clearly whose document is it, and the only thing is that even if the hospital is the custodian of the document, and the information cannot be given to anyone without the consent of the patient. Well, I think we'll now quickly. Some analysis that you do from the medical record department is the following. You can have a bed occupancy rate, you can have a bed turnover rate, you can have average length of stay, you can have the infection rate, you can have a death rate, the accrued death rate, you know, and so on and so forth. All these analysis can be done. Deaths, maternal death, fetal death, work analysis, all the you know. Well, this is patient care evaluation. There's a clinical audit. Clinical audit is tricky stuff that we need to handle, and many hospitals are struggling because they are not probably able to do properly the clinical audit. It is tricky. It is not very simple to do. But these are the things that we can do very simply, and these are elements of clinical audit. Autopsy is not very often done in many hospitals nowadays because we can have a cesarean section rate, we can have post-operative infection rate, we can have a consultation rate, we can have a rate of normal tissue. These are all clinical audits. You can have clinical indicators, they can call it clinical indicators. I think now we can go to quickly to, do you want me to tell them about all these formulas?
Maybe what is the importance of some of these maybe not the formula, but what are the various death rates? What is the importance of knowing gross
all right.
death rate?
So can you calculate infection rate? How to calculate infection rate? So it is the number of infections divided by number. This is something called numerator and denominator. Numerator is number of infection rate and denominator is number of patients discharged during that particular period into 100. So that is the formula. But then there are different kinds of formula. Similarly, there is something called a gross death rate. There is a net death rate. So number of hospital deaths during that period divided by total number of discharges into 100 is death rate. Net death rate is deaths happening after 48 hours of admission, because that is attributed to the hospital death. Before 48 hours, it could be attributed to something external. You know, the patient would have been impending death or whatever. So it's not really calculated. Well, these are some analysis which probably would be done in your books. So I don't think we should. Can you calculate average length of stay? That is very simple to calculate average length of stay, and you must know patient days. This is very interesting terminology. It's a number total patient days during the given period divided by total number of discharges. including deaths. Now, discharges always include death. There is some term called separation, there is some term called acceptance. Acceptance is admission, and separation means discharge, discharge on request, LAMA, and death. So, all this encompasses separation. Turnover interval. Well, turnover interval is very important, and you might have a bed occupancy rate of, let's say, 90% or 95, 85%. So, turnover interval. Maximum. First, let me explain what is patient days. So, if you have an ICU of 10 beds, so how many bed days you are having? A month has 30 days. So, 10 into 30 is equal to 300 ICU patient bed days, and from that you will calculate how many bed days were occupied. It is not necessarily that 40 patients were admitted during that month into the ICU. It is the number of bed days that were occupied, and from those number of bed days you are going to derive how many catheter bed days, how many ventilator bed days, how many these bed. These are scientific things, and you cannot. So you need to calculate the bed days, and you must know what is a bed day. So all these are bed days. So turnover interval is maximum patient days minus actual patient days. That is bed. Do you know a bed complement? What's a bed complement? Okay, and I'll tell you what is a bed complement. Divided by number of discharge and do that. What's a bed complement? A bed complement is total number of beds minus what are not included in the bed complement. So one is the observation beds, which are in the emergency. Number two, the basins. These two are not calculated into the daycare beds. These three things are not calculated into the bed complement. Alright, so they are excluded from the bed count, and do not add them when you do a calculation. Well, that is about the medical records. Whatever little time that we had, we could discuss only this.
I think
we'll quickly turn to mortuary.
After break, we will cover. I think Dr. Das, we have given very comprehensive view of that medical record department, that how it has to be organized, how it has to be planned, what are the various functions of the medical record department. Then you have also told about that how these records have to be maintained, storage, filing of these things. Then you are told about the vertical filings, horizontal filing, and which is the best thing. Kanada, would you like to add something to it, so that some tips to our learners?
Yeah, actually, all the factors have been covered by Dr. Das very comprehensively, but certain gray areas still remain. There are a lot of doubts in the minds of people, like what is the retention time actually prescribed? There is nothing prescribed as such by the government. That might come up in the Clinical Establishment Act, which is being framed and which is being passed by the Parliament. But as such, at a national level, there are no guidelines as such. Every hospital is following their own guidelines based on their own needs. So that retention is a gray area. Then the medico-legal aspects also he brought out very clearly, that they still remain a gray area in terms of whose property it is, whether it is patient's property or doctor's property. Like for example, in the government hospitals under the RTI, everybody is asking document of patients in total, whereas MCI says that you have to give only the summary of the case sheet or the case record, that what all investigations were carried out and what were the, in nutshell, what was the treatment given. So notwithstanding that, RTI is forcing you to give all the complete records. So that these two gray areas I thought I would highlight, and certain debates which go on the OPD records also. Professor Arora has already told about that OPD records is a must, but at the same time there are no clear-cut guidelines in this area about outpatient records maintenance. So I thought.
Thank you, Dr. Rao. Thank you, Dr. Das. I think we will close this session at this particular point of time, and we'll be back after 15 minutes. And then the other areas, sport and utility services area, we will cover in that.